Tony. Our friend Jordan Berlin published at ASCO GI, or has an abstract for this ASCO, I think it is, about TRK fusions in GI cancers. Have you had a chance to take a peek at that, or have any sense of what that's going to show?
Yeah, no, I mean, I think it was presented at ASCO GI, at the physical ASCO GI. And there may be an update coming through at ASCO as well. You know, there were very few patients with GI cancers that, primarily colorectal cancer. Actually, there was a couple of, I think, cholangiomas in the pancreas and appendix. I think there was one liver as well. You know, overall, the experience mirrors what was seen in the general population, both in terms of efficacy as well as the toxicity data. You know, some remarkable responses. You see some durable responses. You know, again, very similar. The median overall survival is you know, was around I think around two and a half years or so. But
Yeah.
you know, with a small sample size, it's very difficult to in a very heterogeneous group and a very small subgroup of patients. Very difficult to say, you know, where that stands individually for the different tumors. You know, those patients respond, and they respond deep, and the responses tend to be durable. I think that's the main message. So when you separate the gastrointestinal cancers away from the overall group, you still see about the same. You know, it is possible that there is a differential response, you know, if you have a salivary gland, or maybe a lung cancer, or perhaps a less pretreated tumor, that you may actually see a deeper and a more prolonged response. Of course, I think the experience, as Luis put it, you know, is too early to tell at this point of time whether there may be variations depending on the site of origin. But overall, I think in GI cancers, we're seeing very similar trends in terms of the responses, their durability, and their depth.
Yeah, Mark, maybe let's drill down on the all-important toxicity. We really haven't focused on that at all. I think you mentioned it earlier in the program about some of the specific toxicities. Can you give us a high-level look, and then I'll ask others to chime in about toxicity?
Yeah, you know, we all, with these very targeted agents, we're all kind of getting used to looking at the kind of grade 3 or 4 columns with the zeros or ones, so which is great. When you look at this particular agent, actually the most common toxicity, all of which was grade 3 or less, was alterations in either ALT or AST, actually most of them being grade 1. To be honest, things like fatigue, some GI toxicity, dizziness is a common thing, but some surprisingly, some anemia, so some myelosuppression. Other GI toxicities, some diarrhea, which we can see with many of the TKIs, a low rate of fever, some arthralgias, body weight gain was another one that stuck out, that stood out to me, headache. But again, if you start to look in the grade 3 or 4 columns, this is very, very uncommon to be either severe or life-threatening. Most of these end up in the grade 1 column and are manageable.
Yeah, you know, the one I sort of come back to all the time is neurotox, and I think you mentioned that as well. You know, when you think about chronic therapy and cumulative toxicities, have others experienced patients with the neurotox, or have any issues that you think should be brought out during this discussion?
So John, you know, normally, just as Mark said, you know, these patients really tolerate this drug well. Even with chronic therapy, you know, they're not like some of the other drugs that we know, that when you go to chronic therapy, you know, that grade 2 diarrhea is not grade 2 diarrhea. If you're getting consistent grade 2 diarrhea, that's not good. That's impeding a quality of life. Grade 2 fatigue is impeding a quality of life. You know, it's pretty bad. What I'm saying is, you know, so we really have to, you know, in drug development now, we're trying to really look at these chronic toxicities. But really, as far as it comes to these drugs, really in my experience, they've been mostly fairly mild. So toxicity, just like Mark said, you know, some fatigue, but normally even with chronic therapy, patients have done fairly well. Some diarrhea has been easily controlled. The neurotox is actually, it's very interesting. It's actually dizziness. So some patients get dizzy. So they need, you know, sometimes in most of the studies, we've done a neuro exam and everything, but that's what we see. They kind of, it's more of a loss of balance than the classic neuropathy. So they do, some patients do experience dizziness, and it could be sometimes bad enough that they might need to use something to walk, like a cane or something, especially if they're older.